I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Thank you for joining me this week for another episode of Fridays with Faisel. I believe that everyone deserves access to quality primary care and should be treated the same regardless of their ability to pay. Today's topic is the impact of primary care on COVID-19. This week, my co-host, Robert, is not able to join us. Unfortunately, he has run into technical difficulties. He's on a train right now, and there's some issues with the Wi-Fi. So sadly, Robert Longyear will not be joining us today. Also, Dr. LaToya Fulton is running into technical difficulties with the computer, with the video and the camera not working. So unfortunately, Dr. Fulton is not going to be able to join. I hope she can. I hope eventually she can hop on. It'll be great because of some of the feedback I've been getting about the full risk model, targeting more affluent patient populations and people who don't have issues with access. And I figured it would have been great to have Dr. Fulton join us today because she's one of our full risk doctors from New Orleans. And she's in the zip code where the life expectancy is only 57 or 58, operating as a full risk doctor, taking on all the social determinants and all the challenges, all the unmet societal needs with the poor in New Orleans. So hopefully she can join in because I would just love to have her in this conversation. I am so thrilled to have Ron Barshop join us today. Ron, welcome. Let me get Dr. Dan McCarter. Dr. Dan.
Hey, Faisel, how are you?
Oh, I'm doing really well. How fun was that? So Dr. Dan and I just finished at the AAFP FMX. We had it wasn't in person. We had to, play the recording. We had a recording of a lecture that we give on scaling out the full risk model. That was a lot of fun.
It absolutely was. There was a lot of energy. A lot of people are obviously interested, a lot of frustration with fee-for-service primary care. So, I feel firmly that, the physicians, we were sold back in the 90s that administrators and business people were going to take care of the business and the doctors just had to take care of the medicine. But now the business is driving the medicine and it's just frustrating doctors to death. So I think it's exciting to be here with you and to talk about the importance of doctors taking back over leadership in medicine.
The importance of primary care, and
absolutely.
The impact of primary care, especially with COVID. So Dr. Dan, you're one of the authors on with the study showing the reduction with mortality with our patients.
Right. Yeah, we had about a 40% lower mortality than the same age group people out in the community. So it's pretty cool. Yeah. Well, I heard a speaker the other day talking and said that healthcare has made specialty care more primary, but it's made primary care much more special. All the specialists are trying to do primary care and not doing it well. And well done primary care has become quite special.
Until Ron comes back, people want to know, and I think that we can show how, when we're taking care of our average patient is 72 years old, 72, 74 years old. And when you're looking at mortality with COVID-19, mortality with COVID-19 is seen the most in the senior population, the very population we're looking after. So
right.
How are we able to reduce mortality by 40%? You're talking almost cutting it in half.
Well, and that's a good question. And I don't know that we know the answer to that. I can tell you, I think part of it was jumping into the jumping into the televideo visits so quickly, doing the love calls. As of now, we got staff when patients weren't coming in and we had to switch to 100% virtual, essentially 100% virtual. We were getting the staff to just call the patients and check in on them and see, do you have toilet paper? If you don't have toilet paper, let's find you some toilet paper. We don't want you walking around Walmart in a pandemic looking for toilet paper. So I don't know that we're not based on what we did, we can say that our results were better. We can't say exactly what part of our model delivered those results. Although it's not that different from the results we get overall with decreased hospitalizations and decreased costs. So I'm not surprised that one disease process, we're getting the same outcomes that we get overall as well.
I think a lot of it has to do with the trust our patients have with their doctors. I really think that's especially in the early days of the pandemic, like all the misinformation that was going around. I think about my father. My father, he's almost 70 years old. He's a ChenMed patient, and I remember, I'll never forget. I was at the airport in New Orleans. We had a presentation in Baton Rouge, and my father had called me, telling me that, hey, don't be scared about what you're hearing on the news. I spoke with my doctor. And he told me that as long as I keep a distance from people, as long as I wear a mask while I'm out in public, as long as I wash my hands frequently, especially before I eat, that we will be okay. Because there was just so much misinformation out there. And I think that's part of the driver with a lot of what we're seeing in the country today. Where are we at now? We're over 200,000 deaths, over 7 million cases, at least that we know of.
Right. Yeah, and I guess I heard last week even that the mortality in this country at this point in 2020 is 20% above what the mortality was last year. So even if you're not accounting for COVID or anything, it's pretty huge. But don't you think part of it is that our patients knew they had their doctor's cell phone number, they could reach out to their doctor. So when they were hearing something they were concerned about on the TV, or on the news, they were able to talk to us about it as well. So, I mean, as near as I can tell, there's the pandemic of COVID that we're impacting, but then COVID sort of unearthed the fee-for-service pandemic that is hitting our primary care brethren in the fee-for-service world.
Yeah, my heart from the AAFP conference that we just left. There's so much frustration. 95% of healthcare in the country today is fee for service. It is a transactional billing system, which is basically a reactive model that is incentivized to generate revenue by billing. And then now you've got these different value-based payments. You've got these hybrid models where there's now, and if you look at the wording, I think about the psychology of doctors, and even the psychology of me as a primary care doctor. When you start talking about words like risk, and you say that, well, Faisel, you and Dr. Dan are full risk primary care doctors. Let's take some baby steps. Remember, we did a workshop with a group of independent physicians. I remember they all said, well, we agree with you that doctors should be in charge. Doctors should be leading the way. But, rather than going there, let us take some baby steps towards value. Let us just do some shared savings. Maybe down the line, we can start taking some downside risk. You see, I think a lot of what we're dealing with here is also the psychology of doctors ourselves.
Right. Well, I think, I think we don't like to take risk, but the other thing about the shared savings is most of those are owned by hospital systems. And I was just telling somebody on the FMX, they were talking about the ACO model. And when I was working in the ACO world, my job was to save money, but not leave any hospital beds empty. Well, unfortunately, to quote Willie Sutton, the bank robber, they asked Willie, why did he rob banks? He said, that's where they keep the money. Well, if you're going to save money in healthcare, you got to leave some hospital beds empty. That's where the money's spent. So being asked to save money, but, and basically what they were asking was to save money, but not decrease any of the money that they were making somewhere else. And so that was quite difficult. So,
I see.
oh
We
boy,
have
good.
Ron, how are we doing with the sound?
I'm great, thank you.
All right. Yeah.
Hello.
I told you. It's like a feeling of an old-fashioned AM talk radio show. That's what we're trying to do over here. That's why. You got Dr. Fulton. Dr. Fulton, you're there?
Yes, I'm here, finally.
All I need now is for Robert to just pop up over here. We got a party. Well, thank you so much. Ron, thank you so much for joining us. Gordon was a guest on Ron's podcast. Gordon Chen's our chief medical officer, and he was a guest on Ron's podcast back in April or May. And when I thought about, the role of primary care with COVID, one of the people that I go to for my information, like my quick update with what's going on in healthcare and in the country, I go to Ron. So Ron, thank you so much for joining us.
Glad to be here.
And Dr. Fulton, you didn't hear this, but in the last couple of weeks, I've been getting messages on social media saying that the full risk Medicare Advantage model targets specifically wealthier patients, patients who have access to resources, patients who don't have issues with transportation, patients who are less medically complex, issues that you're not dealing with all the social determinants. I thought, oh my gosh, we're opening our centers in the same neighborhoods as federally qualified health centers, as community health centers. My background, I was the chief medical officer, one of the largest FQHCs in the country. I thought, who better to explain that now the reality of the full risk model, especially right now with Medicare Advantage and Dr. LaToya Fulton, where there's zip codes in your New Orleans where the life expectancy is only 57 or 58. I just think that's just tragic and breaks my heart to hear that.
Yes. Well, I'm happy to be here. I think that it's been an honor to be with ChenMed, especially during this pandemic, because we didn't have to worry about a lot of, losing our jobs or having pay cuts or things like that. And we were still able to keep our doors open and take care of our patients. The patients that really needed to be seen, we were able to go pick them up, bring them to our office. And then we also implemented telemedicine, which has been awesome. And our patients love it. And so we have patients from all dynamics. Some are very wealthy and some don't have very much. And we're able to work with them all and make sure they have the health care that they deserve. So our patients have been very excited to have us because we were able to contact them weekly to make sure they were okay, they were safe. They often brag about that because many of their family members didn't have that. And we've actually got new patients because of that, because we were able to be there and be there for them. So it's been great, even though certain things occurred this year that we did not anticipate with COVID, but we've adapted and we've continued to educate our patients about what they need to do to stay safe. So we continue to learn more and more about this pandemic. And as we continue forward, we will continue to do what we need to do to make sure our patients stay healthy and safe.
I never forget what you told me when we saw each other. What was it? It was back in February or March, somewhere around that.
I think it was about February, yes.
Yeah, and I'll never forget because I was really curious about the impact with this virus, specifically in New Orleans, where already there's so many issues. And I'll never forget you telling me, well, we could do a lot of doctoring over the phone. And when you said that, I thought, well, what do you, and I said, well, let me know more. And you said that you doctor the patients and their families.
Yes.
That is
and so we still do that. Even now, patients are coming back into the clinics. There are times I still will have them to call their family members, especially if they live with them, to just discuss the ongoing care that we're providing to them. And it's very important to not only educate the patient, especially the population that we're dealing with. We're dealing with seniors. Some of those seniors may have dementia. and things like that. And even though you're explaining things to them, they may not remember. So in that case, it's good to have a family member involved with their care so that they'll know what we're trying to do to help their loved one get better.
You know, Ron, I mean, from our conversation, we just formally connected just in the last couple of days. I think it was yesterday. The role of direct primary care with COVID as well. I haven't seen any of the data there, but I do know that with direct primary care, that they're definitely reduced. I've seen the outcomes where there's reduced emergency room visits, and I think that is driven by the doctor-patient relationship. See, when patients get into that relationship with their doctor, and the doctor is able to focus more on patient care rather than the billing of dealing with the insurance system. Many times I like to compare, I find a lot of similarities with the way that we practice medicine in the full risk model and the guys in the direct primary care world. We're both, I like to refer to us both as being these arrows that are shot out of the fee-for-service healthcare system. There's no going back. The direct primary care guys are way, way, way out further ahead of us. We're still trying to figure out a way to make this work within some sort of the system that's available to us, at least right now.
Well, let's talk about who wins. The winners in direct primary care and value-based care. Let's start with population health before we get to the most important one with your audience, your doctors. Population health, the numbers are anywhere between 30 and 60% less ER visits for full risk value-based care. We know that from your Harvard presentation. The hospital stays are 30 to 60% less than traditional. Your visits to specialists, your needing for lab, your need for imaging, it all drops because a primary care physician's involved. We know from hundreds of studies that anybody with a direct primary care or a primary care relationship is going to live longer. It's like giving up a pack of cigarettes and wearing your seatbelts. And and nothing else, a primary care relationship is going to extend your life. This is beyond a shadow of a doubt. But when you throw in the model itself, direct primary care, value-based care with full risk, which is only 1% of all the value-based care.
Less than 1% of all healthcare in the country.
So this is the pie. You got 100% of the pie. Fee-for-service is 95%. Of the 5% left, you guys are part of the 1% of the 5%.
That's right.
You're like a microcosm in a microcosm.
That's right.
But population health is a winner. So let's talk about the patient. Are the patients happy? Are they getting better care? Well, let's just talk about a panel of 400 for ChenMed or a panel for 600 for a typical DPC. Stop the discussion right there. You get a full hour and a half maybe for the first visit with your doc. You've got full telehealth access on a secure basis. So we can stop. Is the patient happier? They've never like this. They're used to going to a DMV-like experience, waiting in long, hopping and hacking around them, and this is a whole different experience. And
completely different.
Stop at the doorstep, nor does DPC. We used to call it a patient-centered medical home, but it's really when the care doesn't stop at the doorstep of the clinic and it goes into the home, as LaToya just said, that is a revelation for most people. They're not used to being able to access a doctor or a nurse during the day or even at night when they need somebody to have an issue. So think of the time suck from the patient's perspective that goes away when you can text, when you can call, or when you can actually FaceTime, if you will, a doctor as needed. Maybe not right away as you need it, but within a reasonable time, they can get back to you. That is a game changer. And so virtual care, really direct primary care is misnamed. It should be called digital first care. But I had on my show Crossover Health, Jay Parkinson invented virtual care the day that the Apple phone came out. We just had an announcement of a 12 when number one came out before it even had a number on it. Virtual care, he got 7 million hits to do house calls in New Jersey. And so suddenly, in 2007. So today, virtual care, we have companies like Crossover Health has a virtual care, and they're on site with LinkedIn. They're at locations like Facebook. They're at locations. They just got it at the Amazon fulfillment centers, headquarters. That's 1 million patients. 3 million, we just saw an announcement today, 98.6. 3 million patients have virtual care with 98.6. It's a $20 app. Anybody can join, but they got Walmart. So then you can look at companies that are even larger, like Medici. They have 13 million people, with a third of the Fortune 100s are using them for virtual primary care. So these models that allow people frictionless access to patients are a winner. And the third winner, if we're looking at, is going to be, do the employers win, or in this case, in y'all's case, does Medicare win? And with the way we go full risk, Medicare is a big winner, as opposed to most value-based care is kind of a meh valuation compared to the fee for service. It's not a big savings, but high value ACOs like yours, I call it a high value. That is really where the Medicare savings are going to happen. So taxpayer wins and employers win with direct primary care. And the last thing is really, do you have a happy doctor? And I'm going to have to leave that to LaToya. LaToya, do you think the doctors who go to ChenMed conferences are happy?
Yes, I mean, the connection that we have with our patients, it brings a joy that I hadn't experienced before becoming a doctor. And ChenMed is the first job that I've had, and I've been here 3 years. And I absolutely love my patients. And even though they have my cell phone number and they know they can contact me, they're very respectful of my time. And so they will not call late unless it's absolutely necessary. And if I know they're calling me late, something is wrong. And I like that, we are able to do that for them. So it's been great. It's been a great learning experience over these last 3 years of the type of doctor I want to be. And I'm grateful, very grateful. And the fact that, especially during the pandemic, the fact that we didn't have to just worry about how we were going to pay our bills and take care of our family. We just had all that time to focus in on the patients. Because I did have friends that were either laid off because they couldn't keep up. I've had friends that, even ER doctors that I finished residency with, they had pay cuts. And I'm thinking, the ER is like the busiest of all times right now. Why would you get a pay cut? And they did. And so I've even introduced some of them to ChenMed for that reason. I'm like, we don't have to worry about that. So if you're interested, you need to look into this. So I think it has been a great learning experience. And even since when you go through residency, they don't teach you a lot about the business aspect of things. And with ChenMed, we definitely learn how the business works. And I think that has been a blessing as well, to learn that aspect of things. And I see we have more changes coming. We're growing, and patients are happy. And then that's the main focus, to make sure we keep them happy and healthy as possible. And then at the same point, ChenMed has also been implementing things to try to focus more on the providers, to make sure that we are taken care of as well, and we have what we need to stay happy and healthy too. Because if we're not happy or healthy, then the patients aren't either, because we won't have that extra energy to give to them. So yeah, it's been great.
Isn't it a wild culture? A culture where the doctor, and the entire model we have is, you have the doctor at the center of care delivery with the entire care team, surrounded by a care team who does all the non-doctor work. The doctors are more just concerned with the doctoring, and you have an entire organization that is focused on the doctor being a doctor, and then the patients come second. Doesn't that sound wild? I mean, we were all trained, medical school, residency, patient-centered medical home, patient-centered medical home. And we're hearing about this patient-centered medical home concept, and what ends up happening? The doctors get burnt out. The care delivery teams get burnt out. They can't sustain, they can't find purpose in that. They're spending 15 minutes documenting each patient encounter. That's what we've seen. What good are we to the patients if we don't take care of our doctors and their care teams first? I think that's a fundamental concept that we need to shift as a country. We need to focus on the doctors being doctors, and really knowing who to go to when there's a situation like this pandemic that we're seeing right now. Actually, Ron, I'm not surprised that we are where we're at, with all the misinformation, with all the things coming and going. I mean, just look at how the country responded to the flu in prior years. I think this last year we had, as a country, like probably one of the best flu vaccination rates of the country ever with adults. And we almost had half of Americans getting vaccinated against the flu. Not half, almost half. And I believe the reason why is because the incentive in the healthcare system is not there to educate about the importance of prevention with something like influenza. We as an organization, on the other hand, I just shared with you, Ron, this is not public information, but I'll just go ahead and share. A couple of weeks ago, on October 8th, we had already crossed over 44% of all our patients across 10 states being vaccinated against the flu. And it's only early October. Could you imagine where we're going to be by the end of the flu season? I mean, it is a fundamentally different way of practicing medicine when primary care is focused on primary care. Primary care should be focused on prevention and early intervention. And when we're talking about a population in America where the average American is only 37 years old, Ron, everything you're saying with using technology, using the resources that we have available, that just makes sense to me. I mean, the efficiency of moving forward, it makes sense to me. I mean, in our world, for my 3-year-old at least, using FaceTime is not high tech. That's how he communicates with his grandparents. And it is encrypted. It is secure. We should be using the technology, especially for something as important as the health of the country. When we're talking about the most medically complex, we're talking about people over the age of 65, aren't we? The most vulnerable, people on fixed incomes, people with 5, 6, 7 chronic medical conditions. We're talking about people over the age of 65. They only make up 15% of the population. But yet, as a country, out of the $3.6 trillion spend that we're spending on healthcare, we spend over $1 trillion for 15% of our population in this reactive way, in that model, in the 95% of the model being fee for service, meaning that you wait until there's a situation to intervene. You wait until you have to take some action. And what happens with conditions like hypertension, where only 5% of patients end up having symptoms? Headache, blurry vision, dizziness, chest pain, shortness of breath. 95% of people are walking around with hypertension having no symptom in the world. So the role of primary care should be to prevent or intervene as early as possible. And how do we expect patients to trust us with the big stuff if they can't even trust us with the little?
That's true.
Yeah, well, I disagree with one thing you said. You said we need to fix something. It's fixed already. Primary care is cured. It's just cured by companies like ChenMed. It's cured by direct primary care. The fixes are out there. They're just not scaled yet. So you have roughly 100,000 patients this time next year. You're going to have 500,000 in 5 years. You're going to be at 1 million in less than 10 years. ChenMed
you don't think ChenMed could get to 1 million in 5 years? I think we can make it happen. What do you think, Dr. Fulton?
will be there celebrating, brother. If it happens, party, because
I think we're on our way.
we called it here on October, whatever today is. But
let's do it. We'll check it. We'll check back again, 2025, God willing. ChenMed crosses 1 million patients.
The fix is in. I mean, you have the answer, and because you're not backed by private equity and you're not backed by venture capital, your incentives are not maligned. You're not working at quarterly, profits. You're not trying to please some taskmaster who doesn't really care about outcomes but cares about EBITDA, which is really what 99% of care in America is about, is EBITDA. The hospitals don't do well when their heads aren't in beds. So they're not doing well unless there's more sickness out there. So they're in the sick care industry. You guys are in the healthcare industry. You understand the difference? It's light years apart. So if I'm a doctor and I want to go into a meat grinder, I will go work in the other 99%. If I'm a doctor and I want to go make a difference in people's lives, I'm going to go in direct primary care or digital first care, we call it, or I'm going to go to a full risk value-based care. And right now, we're talking about less than probably 5,000 doctors that are in that universe. But if you're lucky enough, like LaToya, like you, to have found a home like this, you're not going to see any burnout with the doctors around you, are you?
No, we create different. I think we create different kinds of burnout. We probably create our own types of burnout. About I can tell you, like for me, I worry when I find out that a patient of mine, say it's a Monday morning, and I find out one of my patients went to their hospital without letting me know first. I mean, that upsets me. Well, why did you let me know? What could I have done to have you give me a call? And you know what they always tell me? And Dr. Fulton, well, we know that you're probably busy with your kids. It's a weekend. We don't want to bother you. And I tell them, I said, for God's sakes, that's why I became a doctor, why all of us became doctors in the first place, to be able to help you in your time of need, not just when you come in for your office visit.
So, Faisel, I'd just like to make a comment. I think Andrew was talking about, at least in one of the practices in Pennsylvania, they had a combination of fee for service and value based, and they were able to use some of the time created from COVID to catch up with their MA patients and catch up and make sure they were getting the risk adjustment correctly, which we all know that's important for risk adjustment, because people do want to get paid, and just wanted to call that out. So the creativity and use of the primary care. But Ron mentioned a term, and I don't know how many physicians we have on with us today, EBITDA. And that's something that not every doctor knows about. So Ron might want to just expound on that a little bit. That's one of those abbreviations that not everybody knows about, especially not everybody that's not into Wall Street. So he might want to give us a little bit more information on that when he gets a chance.
Yeah, earnings before interest, taxes, depreciation, and amortization. So it's a financial term. I call it transaction care. Hospitals are not in the business of making you well. They're in the business of extending sickness and feeding the meat grinder. Urgent care, most urgent care are owned by hospitals today. In fact, 70% of all primary care practice are owned by systems or private equity today. And their job is to be a referral system into a larger system that's more complex, that has lots more medical errors, obviously, because it's a more complicated restaurant, if you will. And so they don't want to take care of you and get you better at home like ChenMed. They want to see you essentially either maintain or get worse. That's sadly the incentive. It's a perversion, to call it, when you're looking at profits of your hospital and your outpatient centers and your surgery centers versus taking care of people and getting them to reverse their weight by walking. I took 10,000 steps today. I've been doing it now. I've lost 45 pounds in the last 2 years and kept it off because.
Wow, good for you, Ron. That is awesome.
And my sleep hygiene is better. And this is all primary care generated by my doctor, by care plan. My hydration is dramatically better. So my moods have changed. But I got off all my medications because I have a care plan from a primary care doctor and through technology, we're able to activate my incentive to stay on these plans. So it's almost as simple as just going out and getting sunlight for a walk. It costs nothing to get your vitamin D. So what are the numbers, Faisel, of the people that have vitamin D deficiencies that also have, they're enormous, aren't they? Like 95%?
Really? It is, I mean, just basic things like with vitamin deficient, especially with vitamin D, we've seen a lot of correlation with vitamin D and just reduced immune response in general. But just what you just mentioned with taking control over your health, with strong primary care, improving your quality of life. And when I think of we're in the middle of this coronavirus pandemic, which is god awful. We know that 80% of people have mild symptoms, mild to no symptoms. 15% have moderate symptoms, and about 5% end up having these severe complications from COVID. We're learning more and more every day. Every day it's just like, okay, what are we learning more about COVID today? And it's looking more and more like a vasculopathy. It's looking more like a vascular disease. And that's why it presents itself in so many different ways. But if we treated COVID just like anything else during this season, like right now, the season we're getting into right now, we're getting into respiratory virus season, right? I feel that the role of primary care with any of these types of, especially viral illnesses, my 2-year-old, he's turning 3 day after tomorrow, and he wasn't eating. So I checked the back of his throat and I saw that his tonsil was a little bit enlarged. That, just to know that his tonsil was just a little bit enlarged, no fever or anything like that. But that allowed me to know more about now what to be prepared for in my household and with anyone else he gets in contact with. You see, it's these little interventions that you nip in the bud, you get ahead of it. You don't wait. We don't want to wait for our patients, our 72-year-old, to get the flu. We already have doctors who have over 80% of their patients right now vaccinated against influenza. Why? Because we know that you don't wait until you start having the symptoms from the flu. Good primary care doesn't wait for that. because we know that the virus, people without symptoms are already shedding the virus for 3-4 days before they even start to develop symptoms. This is what the issue that we have. The fee-for-service system does not value prevention, period. It does not value early intervention, period. Why do you think that we have 800,000 specialists in the country and only 200,000 primary care doctors? Why? The last number I checked, Ron, was like just right around 300,000 nurse practitioners. I think you told me that it's much higher. But even if we have 300,000 nurse practitioners, 200,000 primary care doctors, all this technology that is simple technology. Could you imagine if we had a system where everyone was incentivized to improve health by focusing on prevention and early intervention? That's the world. It exists already today. Ron, you're right. It exists already today. We have it already today. The problem is that we're living in this system that doesn't value that.
Well, good news is you've got good people like Dr. Dan, and you've got Dr. LaToya and yourself who get it. And you have people listening to the show who get it. And it's going to be a slow creeping change. But when you get to 1 million, I can't wait to sell 10 million, because hopefully you'll have copycats. They'll say full risk is the only way to go because the incentives are fully aligned with where they need to be. This kind of hybrid thing where there's people in direct primary care and fee for service, it's the worst of both worlds. People that are in fee for service and value-based care, it's the worst of both worlds. You're still charting at night. You're still 400 patients, but you've really got a much larger expanded patient because you're now seeing them at night and you're taking calls. It's the worst. It's the worst of the best. Like if you pick the best of the worst, you could, but if you're taking the worst of the best, it's the worst life you can imagine. So what y'all done is you've chosen the path of least friction for the patient, for the doctor, for population health, for cost, for the employer, or in your case, the CMS. They're saving money. So everybody is the winner. It's not triple aim anymore. We can throw that away. You guys hit quadruple and quintuple aim. We're way when you have happy patient, happy doctor, happy taxpayer, when you have the happy outcomes and you have amazing costs, that is a winner. It doesn't get better than quintuple aim.
So suddenly the entire system changes when the incentive is to improve health. Especially, Dr. Fulton, I want to share with you a statistic I just read that the average fee-for-service doctor spends 15 minutes documenting each patient encounter. And that's with an average patient, the average American, 37 years old. So when you look at the fee-for-service system, the fee-for-service system is more concerned about the medical complexity of the patient documentation in order to get reimbursed a higher level visit or whatever it is, than they are with the medical complexity of the patient who's sitting right in front of them.
Correct. And that was one of the things that drew me to ChenMed when I interviewed, because they explained to me that wouldn't be a thing that I would have to deal with. And since I've been there, I'm able to spend more time just focusing on the patient. And most times, after you're done with the patient, even while you're there, by the time I'm done, you can complete your charts. One of the reasons we can do that is because you don't have to necessarily focus on everything that visit, because I can bring my patients back as much as I want. Some of my patients, especially if they're dealing with congestive heart failure or COPD and they're having an exacerbation. So at that point, I will explain to them when they come in to see me, if we need to bring you in here every day until you're better, we can do that. And some of them are excited to hear that because they live alone. And so they're afraid. And so just the thought of being able to come to the office and get the care they need, they are very excited about that. And one case in particular I'm thinking about, there was an elderly lady here. She had no family here in town, so she was pretty much alone. And she voiced to her medical assistant that, she was just afraid to be at home. And we were able to contact her family out of town to let them know what was going on with her. And so they were able to come and get her, but they said it would be like a 2-week time span. So we actually picked her up every single day. We had her own little room set up, brought her into the clinic every day. and just loved on her until they were able to come and get her. She was very sad to leave us, but she was happy that her family were coming to pick her up because she had become very afraid to live alone. And so instances like that, when you're in the fee-for-service world, you don't have time to stop and do things like that. And so that's one of the things I'm really excited about with ChenMed, is that I can do those things for my patients and just make sure overall their health may be fine, but it may be a social issue that they're battling. And so that gives me an opportunity to also take care of that issue with them as well.
Faisel, Alan Rodriguez asked, do you have reading recommendations for young physicians to learn more about different models of healthcare delivery? And I wonder what Ron has to say. Say Solomon mentioned the Long Fix by Vivian Lee. I know I like Reframing Healthcare by Zev Newworth. I'm wondering what Ron, does he have any recommendations for books to learn more about different delivery models?
Well, I've been hooked on Eric Topol the last couple of weeks. I've read all three of his books, and he's talking about how artificial intelligence is going to be such a big factor, and it's not going to be. It already is. It's obvious in radiology, where you can now get better reads. It's obvious in dermatology, where your skin condition can get read by basically digitally, and now coughs. You can actually listen to a cough and tell exactly what the condition is. Artificial intelligence. So the questions about models, there are lots of books written by Paul Thomas. Just wrote a book about direct primary care that I'd recommend. Paul was one of our guests, and he's with Plum Health in Detroit. So if you want to learn about direct primary care, that would be a book I'd recommend. Value-based care, I don't really study it, but listening to podcasts, we just had Clive Fields on our show with Primary Care Cures. Clive is with one of the largest ACOs in the country. He just did a deal with Walgreens, $1 billion deal, and he'll be in 500 to 700 Walgreens with a value-based care ACO. And then Catalyst Health, anything with Chris Crow on it, or Clive Fields, or anything with Dr. Chin on it, you're going to learn a lot on podcasts, because you'll learn the most current thing. Books are outdated the second they're published by their very nature.
Yeah.
Oh, we can't forget Dr. Marty McCary, The Price We Pay. My gosh, I mean, that book alone, I feel like every medical student should read that book. I mean, I had the pleasure of meeting Dr. McCary back in around that time frame. It was around January, February, and I was really fortunate to spend the morning with him. He had come to Miami to see our operation, and that book for any medical student. I mean, that's a book that really helps you understand what we're talking about. When people say, "Oh, we can't afford to do this," or "We can't afford to do that," you'll quickly learn that we're already paying $10,000 for $10 pneumonias. I mean, my pneumonia, I had pneumonia 2 years ago. This time, I went to a standalone emergency room. Ron, we have standalone emergency rooms all over Florida. I'm in Tampa. And the hospital systems have made a business over hemodynamically stable patients to be fast-tracked in emergency room settings that are attached to the hospital and standalone emergency rooms, where I had a chest X-ray, I had I had normal saline, I had acetaminophen, Tylenol, I had 2 different types of antibiotics, Rocephin injection, azithromycin, oral, and I had an EKG done. And the bill was literally $10,000. My insurance ended up paying about $6,700, $6,800. And ironically, actually, I'm one of the 1 in 5 Americans in debt collection because of medical billing, because there was $19 that wasn't paid from that. And I didn't know about it. And I got a letter in the mail. I saw my credit score fell to like 670 or something. And we saw it was because of this debt collection, $19 bill. And speaking of which, when we're talking about medical billing and medical debt, 1 in 5 Americans is in some stage of debt collection because of medical billing. And actually from Ron, I learned, man, I knew that the number 1 cause of bankruptcy now in America is medical billing. And Ron, actually, you told me it was some ridiculous number. I mean, that it's like the main cause of bankruptcy in America now. It's like, what, 2/3? What was it that you said?
Yeah, there's reasons people, there's 10 big bankruptcy is all the rest of it. So it's twice as all the other reasons bankruptcy. But the sad thing is that the average American makes under $13.80 an hour. 50%
Wow.
of making that much. The other half of America makes more than that. So half of those people are literally, they can't put $400 together, and their deductibles for these high deductible plans are easily double that, $400. So they have a plan, but they can't afford to use their plan. They have good insurance, but good insurance they can't tap. What does that mean? That means they're functionally uninsured. So we learned about 20 or 30 million Americans are uninsured. What about the functionally uninsured that are about 60 million?
60 million. Yeah. What good is it if they can't afford their copays or deductibles? What good is it anyway? You're gonna wait. You're gonna push through, and you'll end up in the emergency room.
I think 90 million Americans see this treehouse care for the rich. They can afford it. We can't. I think some of that's what's marching on the streets. Some of that's what's frustrated with politics, frustrated with not voting, or even coming out to vote and just voting against everybody. Nobody has really solved that problem, which is you have insurance, you can't use it. You want to see a doctor, but half millennials have never seen a doctor, especially the males. The females at least get their pap smears, but that is a big problem when you don't have a relationship. Well, now you can go to direct primary care, and for anywhere from $20 to $80 to $100 a month for your whole family, you can now go get care. With 98.6, another company out of Seattle, you can get $20. You can go see a doctor immediately. And again, for your population is over 65, they don't have, Medicare's great. It takes care of them, and especially if they have somebody like you caring for them. And I'm really glad to see ChenMed coming to Houston, Texas with clinics. That is, Texas needs more ChenMed.
You're in Houston. He's in Houston. That's right.
We want more ChenMed.
I cannot. I'm really excited about our expansion into our 11th state. Hard to believe it. LaToya, can you believe that? We're moving into 11 states. I want to thank you both for joining us this week, talking about me. We kind of went all over the place with primary care. I guess that's bound to happen. You're talking about the role of primary care with COVID-19, and then you can't help but want to talk about the role of primary care with chronic medical conditions in general. The role of primary care should be focused on prevention and early intervention. The system that primary care doctors and really the entire healthcare system should be focused on restoring the doctor-patient relationship, which is a sacred relationship. If you look back, we've had written history now for 5,000 years? The doctor-patient relationship has always been a sacred relationship. It used to be a sacred one before it became this financial one that we all know today. Dr. Dan, I'm sorry, you just popped back in here. You got probably...
No, I just...
But yeah, we kind of went all over the place with primary care, and I think that was bound to happen. We're talking about COVID is top of mind right now. Obviously, we're seeing the mess that happened with lockdowns and all of this stuff with COVID and the way that COVID was managed in the country. But to me, it wasn't a surprise at all. It wasn't a surprise at all with something like influenza, which we have vaccines readily available. Shame on all of us that you have vaccines readily available. In fact, my wife told me that we had to get our flu vaccine. We have, here in Tampa, we've got a grocery store chain called Publix, and they offer a $10, one of these $10 gift cards if you get your flu vaccine. I mean, you can't go there. I don't even think you go to a gas station without being offered a flu vaccine because the culture is not focused on prevention. It's not focused on early intervention. That's why you have so many diabetics. I mean, you have over 100 million Americans who have prediabetes or diabetes, and how many of them are diagnosed in the emergency room setting? And what are they started on? They're not started on metformin. They're started on insulin, and we see them run in our world. We see them when they come into the Medicare world, and they've been taking insulin for decades because that's what they were started on, and people just keep refilling insulin. They come see like a LaToya Fulton or me or Dr. or any of the full-risk doctors, and we start talking about lifestyle, and suddenly you get them off of insulin, and they think that you're God's gift to medicine. They say, no, well, actually, the system, I mean, it wasn't malpractice, but it definitely wasn't efficient with the way that your diabetes was managed.
So one of the other things I wanted to mention that I hear a lot from new patients that join ChenMed is that, many of them often say it's crazy that they had to get old to get really great health care because they enjoy the health care that they get now. Over the last year or so, I've become more familiar with direct primary care as well. Dr. Delicia Haynes and Dr. Paul, actually, I've had a few conversations with. And so with direct primary care expanding as well, then more of the younger generations can also get that health care, and they don't have to wait till they become seniors to get the health care that they deserve to have. So I think great job to both ChenMed and direct primary care, both awesome organizations. So
it's wild how you get doctors and systems saying that we're done with this. We're done, and people are too. Actually, I need to find probably a direct primary care doctor myself here in Tampa, so that I can have access to a doctor whenever I want. So it's not just I try not to do the doctoring in my house.
As of once you go DTC, you'll never go back. That's I have two employers on my show. One was a utility, so they're like a Time Warner Cable. They're the internet provider for East Texas. And then I had another who was one of the 10 largest drywall contractors in the United States. Both who went direct primary care and would never go back. They'd laugh and they would never go back to the old way. And it's the same with once they found ChenMed, they're never going to go back to the old standard of Medicare because it's feasible that they that kind of lack of attention.
And I've actually even
billing. Could you imagine, like Dr. Fulton? We don't have a billing department. We're in 10 states right now.
Right, we don't.
We don't know what that is. I don't know what that means.
And I've even had patients before that have left for whatever reason. Usually it's because someone called and offered them a cheaper rate. With them being gone maybe a month, they were calling me asking could they come back because they didn't want to be in that system anymore. And so of course we were happy to bring them back. And now, they cherish what they have even more because they step back into the fee-for-service world and they realize, you know what, I can't even get to my doctor. I've been calling them for a couple of weeks and nobody's called me back. And I've had a few patients like that, and they've called me because they still have my cell phone number. And when they decided to leave, I told them, keep my cell phone number. If you have any problems at all, I'm still here for you. And if you need me, I'm here. And so when they ran into those issues, they called and it was like, is there any way possible you can get me back into ChenMed or GenCare? Because we're called GenCare here in New Orleans. And so we were able to get them back in right away. And they were very happy. And they said they would never make that mistake again to leave because now they know what they really have, especially with the fact that if their car is broke down or they can't get here, they don't have family here, we can go get them. And they love that they can get to us so, frequently or readily as needed.
It's incredible when a patient becomes a patient and they're not just a diagnosis. They're not just a combination of this is Mr. COPD, CHF, hypertension, diabetes. This is not. This is a sacred relationship. After all, at the end of the day, I think about every doctor puts on a personal statement or a note somewhere. There was a letter when they were applying for medical school. Why are we pursuing medicine? We got into medicine to help people. We all have that in there. And then you get out into the world and you find out that you're just this, what do they call it? The cog in the wheel. And it doesn't need to be that way. It absolutely does not need to be that way. Well, we've gone way over time today, which happens. It happens. I know. And it was Ron's fault probably because Ron told me, he warned me, he said, I'm going to get you fired up. And it's true, he did. I did. And then probably the combination also too with the AAFP FMX, definitely probably the highlight of my life. I cannot believe it. We were just attending it last year. Here we are today presenting at it. That was a treat as well. Dr. Dan, thank you so much. This was, what a fun ride it's been. I wonder how fast we'll get to where, I don't think it's a matter of if, it's like, when are we going to get to the million patient mark?
That's right. Yeah, no, this was great. It's been a great day. It's been a lot of fun sharing, the importance of primary care and COVID and the importance of value-based care. And I just see doctors feeling beaten down, and they don't have to be beaten down. There are options, but you're going to have to move to make the option very often. And that waiting for somebody else to fix it's going to be difficult.
Yeah, I'm getting more and more. I was telling Ron just the other day, more and more doctors and independent doctors reaching out to me to actually buy their practice. That's never happened before. That's never happened before. more and more young doctors who want to know about, well, what is it like being compensated in the full risk model? And when I tell them that, actually we level the compensation playing field. We actually, in fact, I believe that primary care should be paid more many times. I feel like the work that we're doing is much more valuable to prevent or intervene earlier than waiting for the problem, for complications to all happen. Be a great topic for another day.
That's right.
Well, Ron, thank you so much for joining us. I'm just you're going to have to be coming back. I'm going to need you at least everybody coming back at some frequency.
Be fired up.
And Dr. LaToya, thank you so much for joining from New Orleans. Thank you. Today's our day off. Thank you so much for joining us like this. Your voice, living the full risk model for many who are still debating and contemplating, taking baby steps with shared savings or baby steps with some value based, with some downside risk. And many times I feel like the hybrid models are worse than fee for service. Fee for service, you got to spend 15 minutes documenting each patient encounter. With these hybrid models, you got to spend all this time in between patient visits doing documentation. It's like worse in many ways so far as burnout is concerned. So thank you so much. And to our audience and our guests, thank you so much for joining us today. For more information about what we talked about, especially with the article that we just had published in the Journal of Preventive Cardiology, where we show that we've reduced mortality by 40% in our patient population, as well as a full risk value-based care model in general, please visit chenmed.com/resources. I believe healthcare is a right, not a privilege.